Hello, thank you for joining me for this learning activity as a requirement for teaching strategies in the health professions. My name is Lori Humiston, and I'm going to be talking about collaborative care models and scaffolding professional identity through learning. The title of my learning module is Knotworking in Hand Therapy, using foundational concepts to scaffold professional identity and collaborative communication. This educational activity is a recurring component of a learner's community of practice for OT Hand Therapy Fellows. It provides scaffolding for mastering foundational concepts, developing collaborative communication skills, and forming attitudes that reinforce professional identity and interdisciplinary roles. It is based on a cultural historical activity theory and a knotworking model of activities. I'm going to start with a review of the difference between collaborative care teams versus interdisciplinary care teams. In today's healthcare environment, we have undergone a significant transformation over the last 20 years. What was once a hierarchical delivery model led by physicians has adapted to reflect innovations in medical knowledge and treatment specialties. Now, delivery is patient-centered rather than physician-led. Care delivery now often utilizes providers from various specialties, including, but not limited to, internal medicine, neurology, rheumatology, and rehab providers. Placing the patient at the center of this collaborative effort requires adjustments to roles, creating opportunities for flexing priorities and challenges in managing collaborative tensions. The transformation in healthcare delivery has affected medical clinical education to ensure that entry-level providers possess dual roles within their care team. A strong professional identity that fosters confidence and competence in delivering patient-centered care, and an adaptive and collaborative interprofessional role that promotes a balanced approach to multidisciplinary care. Clinical education for health professionals aims to achieve both of these goals and many others. The cultural historical activity theory, otherwise known as CHAT, is based on activities that are highly relevant to clinical education experiences. According to Larson et al., cultural historical activity theory focuses on how people use tools, such as physical, like documentation, or symbolic, like language, in multifaceted social contexts to achieve specific objects, like developing history-taking skills, that lead to anticipated outcomes, like the delivery of optimal patient care. The unit of activity theory is represented by the model shown here in Figure 2.6 of Learning by Expanding, an activity theoretical approach to developmental research from Engstrom in 2015. In my activity, the people are learners and patients. The tools used for this learning activity are symbolic representations of foundational treatment modalities for providing hand therapy, and the social context aims to learn how to prioritize different foundational concepts with a patient's goals and priorities. The anticipated outcome is the delivery of collaborative and optimal patient care. Now we have a couple of busy slides here, and that serves to represent how complex and interdisciplinary hand therapy is. So here we're going to start with an activity systems model, demonstrating the tensions and contradictions in an organizational activity system. This one represents a collaborative care team that includes patients, hand therapists, specialty practice providers, and general practice providers. The cultural historical characteristics of the activity system are the hierarchical model of care provision centered on medical leadership and a holistic education of rehabilitation providers in musculoskeletal injury assessment and treatment. You see that successful delivery of care is rooted in interprofessional communication and democratic exploration and negotiation for priorities in patient-centered care. As you go around the model, you will see that the tools here are care provision, documentation, and cost reimbursement. The objects that relate to the patient are care provision, assessment skills, holistic care, and comorbid prioritization. The division of labor is a clinical role for providers, but also an educational role in teaching hospitals. The communities working within this system are the hand therapist team, the larger rehabilitation therapy team, consisting of OT and PT in this situation, the orthopedic medical team, the physiatry medical team, and the faculty team, which is responsible for the curriculum. The rules that apply to this activity system are clinical tasks, educational tasks, regulatory compliance for care and educational programs. And then the subjects that operate within this activity system are the interdisciplinary team, consisting of the general practice provider, the specialty care providers, and the allied health team or the rehab team. In addition to the tensions of the communities and subjects you see in this activity system, teaching hospitals are consistently adjusting to the interdisciplinary model of care while managing tensions created by a hierarchical institutional model for mentorship and supervision of care and the turnover of learners rotating on and off care teams. On this slide, we're going to focus in on the patient and provider characteristics operating within this activity systems model. The patient characteristics, typically in those seeking hand therapy, are limited access to care, as there is an ongoing drain of hand therapy providers, market forces on costs for care delivery, health literacy competence, asking, what is a hand therapist and what can they do for me? And complexity in comorbidities. The hand therapy provider characteristics are that they're highly skilled in musculoskeletal upper extremity assessment and contributing factors from comorbidities. They address the physical, emotional, and functional impacts of upper extremity injury. Learners in hand therapy are situated at the intersection of the patient and provider, as well as the learner and the practitioner. These social roles create tensions for the learner that can make mastering content to become a proficient therapist very difficult. The learner experience consists of building the knowledge, skills, and abilities of a hand therapist, while also developing a sense of belonging to the roles of a learner, mentee, a care provider, and a collaborative care team member. Prioritizing the patient experience and its characteristics can create contradictions and tensions for the learners in their other roles. Here we look more closely at the learner activity system that applies to members of a hand therapy fellowship. This is a student activity system, and the tensions, contradictions, and priorities that are competing for the student's attention and energy are further explored in the model you see here. Here, the tools for the learners are their learning objectives and any resources that they may be using to accomplish those objectives. The object is still the patient, providing care for the patient, assessing their needs, providing holistic care, and understanding the comorbid prioritization. For students, they also have a learner role and a clinical role that divides the labor that they have available to spend. The communities they belong to are the hand therapy team, the larger therapy team consisting of either OT or PT, depending on which profession they are rooted in, the orthopedic team, the physiatry team, and the student or learner team. The rules are applied as clinical or educational tasks, and the subject is the learner or the fellow. Learners in hand therapy are working with a variety of teams during their clinical education, further diffusing their sense of belonging and growth within these teams while trying to align with their professional identity. These contradictions impact communication strategies with their mentors, patients, and collaborative care team members. Managing learning and communication in these systems can be overwhelming, resulting in cognitive overload. The formative learning activity that will be presented here offers a scaffolded experience that reduces cognitive overload, enhances professional identity and growth opportunities in team collaboration and communication, and helps learners prioritize proficient patient-centered care in a safe environment where they're not experiencing the strains and tensions of an actual care provision experience. So here we come to the learning activity itself. It is a process called knotworking. The image here is adapted from an image that was depicted in the article by Larson et al. Titled Tying Knots, an Activity Theory Analysis for Student Learning Goals in Clinical Education, published in 2017. Knotworking comes from cultural historical activity theory, and it is a representation of the tensions and strains of competing perspectives when pursuing a common goal, like an interdisciplinary collaborative care team. It is gaining popularity in clinical interprofessional education because it supports learners in both self-regulated or determined knowledge learning and collaborative skill building. Both of these are essential for collaborative care teams. And here we come to the learning activity, which is based in a process called knotworking, where the learners are assigned a role identity that allows them to approach the activity from their assigned role in the patient diagnostic picture so that they have limited content to be responsible for, thereby reducing their cognitive load. Their role or their aim will be to advocate for their assigned system within the collaborative care discussion, simulating a collaborative specialty team discussion. And here we have the skeletal system represented in the knotworking diagram, and that aligns with an orthopedic team. The connective tissue role aligns with the rheumatology team. The musculature and psychosocial align with the rehabilitation team. The peripheral and centralized pain align both with neurology and psychology. Learners collaborate and negotiate with other learners in a peer mentorship model to determine their relative roles and priorities, developing a multifaceted care plan, providing proficient patient-centered care. I did want to mention that this diagram was adapted using an AI schematic that used the diagram taken from the article by Larson et al., published in 2017. And here we see the characteristics of the target audience of learners. The profession is an occupational therapy fellow in a hand therapy fellowship community of practice. The level of learner is a licensed graduate of an occupational therapy professional program. They are in various locations with different learning resources and mentorship sources. And this activity aims to provide collaboration supports for equitable learning through shared resources across the group. And these are the learning objectives for this activity. There are both performance and learning goals or learning objectives here. The performance goals are at the beginning, applying directly to the fellow and what they will accomplish. The initial one indicates that the fellow will partner with an academic mentor or educator to develop an accurate representation of their assigned role. And that two, the fellow will apply their assigned role in the case provided with appropriate prioritization according to the patient's goals. And then the last two are learning goals, that they would effectively communicate with a small group to employ a collaborative approach, resulting in a multifaceted patient-centered learning, patient-centered care plan, and that they would recognize the tensions and contradictions between their assigned roles and select options for addressing them in a professional manner. You see the educational strategies here and other methods. The educational strategies are self-directed learning, spaced learning, as the fellow will be assessing and determining their role with their mentors prior to the learning activity, and then elaborative learning within a small group. The personnel participating in this activity are mentors, educators, and fellows. And the tools used would be educational materials, which would be pertinent research to the case vignette, books for foundational concepts, and experienced mentors and educators to share their subject matter expertise, as well as technology in the form of computer software for virtual communication like Zoom, Google Meet, or Microsoft Teams, and for concept map development, which we will see next in the assessment strategies. Here's my assessment strategy. The first assessment you see in the right column are for the self-directed performance objectives, and they indicate that the fellow would perform in collaboration with their mentor team, which will be worth a number of points, to create goals consistent with their independent learning plan, and then using Bloom's taxonomy to frame their goals. And then the second assessment strategy would be for the learning goals, that they would, the fellows would work together to create a concept map to represent a multifaceted, fully integrated plan of care with clear reasoning for prioritization of the assigned roles within the care plan. I'm emphasizing the self-directed learning and performance portion of this learning activity at this time in an attempt to decrease the emphasis on the collaboration to prevent any cognitive overload or stress that may cause the learner. We would see how well that worked. So to wrap up, this cultural historical activity theory and knotworking using foundational concepts to scaffold professional identity and interdisciplinary roles aims to provide mastery of foundational concepts in hand therapy that would support clinical reasoning, that the fellows would collaboratively create a concept map indicating learning, and represent a multifaceted, fully integrated plan of care. Thank you for your time, and here are my references that were used in developing this activity. Thank you.